I was recently contacted by the mother of a child that I cared for about 5 years ago when I was working in a practice. She was concerned about her 9-year-old daughter's asthma. The details shared by Mom really worried me, and in view of the fact that her daughter had what we call a near-miss asthma attack, that is, an attack where things could have gone tragically wrong for this little girl, I decided to do this podcast on this topic. So I'm sharing the details with the permission of her parents, because this child's story could help other parents to recognize when they need to ask for a specialist referral. In addition, doctors and other healthcare professionals caring for people with asthma, particularly children with asthma, and also receptionists who work in primary and in emergency care departments, could also learn from this story and take more care when consulted by a person with uncontrolled asthma in the future. Now, before I continue, please do click on the follow button of the Asthma Spotlight podcast. And if you find these podcasts helpful, please do share them with people with asthma and also healthcare professionals dealing with asthma. I'd seen this child when she was about 5 years old. Her asthma at that stage was not well controlled, and she responded very well to a low dose of inhaled corticosteroid preventer medication, which she had remained on since then. In August last year, the child saw the asthma nurse in her practice for an asthma checkup. Her asthma was well controlled on the inhaled corticosteroid preventer inhaler, and for some reason, the nurse advised Mom that her daughter shouldn't be classified as having asthma any longer, and that she didn't need her asthma medication anymore because she had been well. Now, fortunately, Mom quite rightly decided not to stop her daughter's medication. In September last year, the child had a severe asthma attack requiring ambulance transfer to the hospital accident and emergency department. After waiting for the ambulance for 2 hours, the child was taken to the emergency department at the hospital and was then left to wait 10 hours until she was seen by a doctor. By that time, because her observations had settled, the doctor discharged the child with a course of steroid tablets to treat the attack. The doctor did provide Mom with an asthma leaflet and advised them to see the asthma nurse at the GP surgery in a few days' time. Mom had great difficulty trying to get an appointment for a post-attack review, which had been advised by the hospital doctor. And when the child was seen by the practice asthma nurse, in fact the same nurse who had seen her a month before, she did not make any changes to the treatment, nor did she request a doctor's review of the child who had just had a severe asthma attack. In fact, she wrote in her record that Mom feels the need to continue using the inhaled corticosteroid preventer. The fact that this child had recently had an asthma attack and that she was still on the low-dose inhaled corticosteroid that I had prescribed 5 years earlier should have alerted the nurse to the need to increase this child's dosage of her medication, or at least to ask a doctor to review the child who had just had a severe asthma attack. Once again, Mom fortunately continued to give her child the inhaled preventer medication. 6 months later, in March, just a month ago, the child had another severe asthma attack, which had life-threatening features. That attack had started at school, who had followed the child's asthma action plan. They'd given a dose of reliever medication and called Mom. The child was very ill, and Mom had by now bought an oximeter to check her child's oxygen levels, which were very low at that time. So Mom appropriately gave her child extra reliever puffs and contacted 111, who advised the mother to take the child directly to hospital. At that stage, the child had needed 22 puffs of her reliever inhaler, and her oxygen readings were at life-threatening levels. Now, because the ambulance service had taken so long to attend for the previous attack, Mom decided to follow 111 advice and take her child directly to hospital herself, rather than to order an ambulance. Now, at the emergency department, the child's observations were apparently satisfactory. Not surprising, really, after 22 puffs of reliever inhaler in the preceding 2 hours. And then, after waiting 2.5 hours in the casualty department, the child was seen by a doctor who, according to Mom, said there was no need for the child to stay in the hospital and discharged her with a course of cortisone tablets without any follow-up. Once again, the asthma attack was treated and the child was discharged without any arrangement for follow-up by a specialist pediatrician. This second attack was clearly life-threatening, and the mother had informed the hospital that her oxygen saturation levels had dropped down to 72% at one point. In fact, they ranged between 72 and 89% before coming to the hospital. And in view of this life-threatening attack, it is really surprising that no arrangements were made by the hospital doctor to arrange or organize a pediatric asthma specialist follow-up. So Mom was very concerned, and after telling the practice receptionist that she was concerned about her daughter, she was seen by a very helpful, experienced nurse in the practice who arranged a referral to a pediatrician at the local hospital. Now, having heard this medical history when Mom contacted me, I was extremely concerned about the safety of this child, and with the mother's permission, after discussion with a specialist in pediatric asthma in London, I asked the practice to refer the child to this specialist, on whose advice the practice immediately increased the dose of the child's medication while waiting for the specialist appointment. Now, spacer was also prescribed. However, the pharmacist issued a spacer device with a face mask. And in the case of a 9-year-old child, this is clearly inappropriate. The mother queried this with the pharmacist and eventually got one with a mouthpiece, which was more appropriate for children over the age of 3 years. The family saw an asthma specialist pediatrician a few weeks ago, and fortunately, the child is now doing very well, and her care will continue to be supervised by the specialist because of the recent life-threatening asthma attack. And for those of you that have heard me speak before, you'll remember that if someone has had a life-threatening asthma attack, they are at risk of having another attack, and specialist follow-up is really very important. So what are the problems with the management of this little girl, and why am I so concerned? And in fact, why am I so distressed to hear this story? At the time of recording this podcast, we're approaching the 10th anniversary of the National Review of Asthma Deaths, the NRAD, which I was the clinical lead for. Now, while we don't have many childhood asthma deaths in the UK, most of these cases are preventable. And also, we always hear about the tragic cases where children die from asthma, but we don't hear about the cases such as this child's story. And I'm quite sure there are many of these which we don't get to hear about them. And so in this child's case, she had a near miss. I mean, this case could have gone tragically wrong. And we call this a near miss. In other words, that's where there's a life-threatening asthma attack, which is poorly managed and could have gone very tragically wrong. So 10 years after our very clear recommendations in the NRAD, which included that inhaled corticosteroids are the most important treatment for chronic asthma, that asthma attacks should be taken seriously, and that an asthma attack means that something serious has gone wrong, and that anyone having 2 or more attacks in a year should be referred to an asthma specialist, and finally, that asthma care should not be delegated to untrained individuals who do not have the competencies or the abilities or the supervision to manage cases of asthma, in particular post-attack reviews. And so I learned about this frightening episode in this child's life where none of these recommendations had been followed. So the main reasons for my concern relate to the dangerous advice given by the practice asthma nurse, the failure of the emergency department to ensure that this child saw a specialist pediatrician after her second episode, which was a life-threatening attack, and the failure of the general practice to proactively ensure a timely post-attack review on both occasions, and also to refer a failure of the practice to refer a child to a specialist before the mom contacted the practice and asked for help, and also before mom contacted me. So those of you who've listened to my podcasts or lectures will know that I keep saying that asthma is an ongoing chronic disease. It's not an acute disease. It's a chronic disease that is prone to flare-ups or asthma attacks from time to time. And therefore, it should not be treated as if it's an acute illness, where the acute attacks are simply treated without being followed up to find out what went wrong and what factors could be improved to prevent a future attack. Now, the important message is that these attacks should not happen if asthma is well controlled. And this child's asthma was pretty well controlled when she saw the nurse in August last year. And for some reason, which I cannot fathom, the nurse decided it was safe to stop the very treatment that was controlling the child's asthma, even though the treatment at that stage was a very low dose. So if an attack does happen, that's a signal that something serious is wrong, and an urgent review by somebody trained to do so is needed. And also staff who are in the front line, and this is reception staff included, need to be very wary that asthma attacks can go wrong, they can be very dangerous, and also if someone's been treated, if they've had their reliever medication, they might not look too bad at the time. Now, this child was seen twice in the accident and emergency department for asthma attacks, one of them life-threatening, without seeing or being referred to a specialist pediatrician. This should not be happening in 2024. So a key message for parents is to insist on a specialist review if your child has had a severe asthma attack, and certainly if your child has had 2 or more attacks in a year. Ideally, this should be done while in the hospital, but otherwise ask and insist on a referral by your general practitioner to an asthma specialist. Now, the next problem was that this child, having been brought into hospital for the first attack, I should add at the insistence of the paramedics, because her oxygen saturation was low, and they felt that this was probably a severe asthma attack and she needed to be seen in hospital. So when she arrived in hospital, she was left there for 10 hours in the emergency department before she saw the doctor. Now, Dad, who was there with her, made repeated requests of the reception staff in A&E to ask for a doctor to see his child urgently. And they were told, you've just got to wait your turn. Now, this is really risky and possibly dangerous in my view. I know that the emergency departments are busy and stretched. However, reception and triage staff should be aware that an asthma attack is a clear emergency requiring urgent clinical assessment and management. And for parents, you should keep reminding the reception staff that your child is in the ED because of an asthma attack and ask for a doctor to be alerted about this. The same applies when you attend a general practitioner and are left in the waiting room to be seen. Now, the next problem was a long delay in having a post-attack review in the general practice, and this only happened because Mom had insisted on an appointment. There are 3 issues there for doctors and nurses working in primary care, and the first 2 relate to treatment of asthma attacks. As an asthma attack means that something serious has gone wrong with the ongoing chronic care, anyone who's had an attack needs an urgent review after the attack was treated, ideally before the corticosteroid tablets run out. and ideally it should be within a few days of the attack being treated. Now, the short course of oral corticosteroids are often only prescribed for 3 or 5 days, and that's why it's really important to see a doctor or a trained nurse before they run out, because you might need more. So the review is to find out first if the attack is over, and if it's not over, either more treatment or re-referral to a hospital is needed. And secondly, the post-attack review is to find out what can be changed, what went wrong in the person's care. So how can future attacks be prevented in that particular person? For example, by correcting poor inhaler technique if appropriate, or in the case of this child, by increasing the dose of the inhaled corticosteroid or adding an extra drug to that inhaled corticosteroid, according to the guidelines in practice at the time when this child was seen. The third issue for doctors, particularly in primary care, relates to delegation of care to untrained individuals, which I'll talk about in a moment. Now, in my view, after an asthma attack, a detailed asthma review check should be done by a healthcare professional to see what, if anything, could have been done to prevent the attack and to take appropriate action, by changing treatment if needed to prevent a future attack, and also to change any systems in place in a practice which are identified as problematical in the way that care is provided for all patients with asthma in primary care. In this case, the nurse was clearly not adequately trained and not adequately supervised, and also there wasn't a system in place to ensure that patients are seen urgently after acute asthma attacks. Now, that second severe life-threatening asthma attack that happened a month ago was a preventable near-miss attack. And thanks to the mother's appropriate quick management on the day and her assessment of the oxygen levels, a tragedy was prevented. I've published a recommendation for general practices to set up systems to ensure that anyone who's had an attack should be reviewed in detail by a healthcare professional, and this should be discussed at a practice meeting. Please see the link in the notes to my 7-step plan for general practices on my website. Now, a major problem relates to the dangerous advice given to mom by the practice nurse who was designated as the asthma nurse. Now, this nurse advised her mum that her asthma was well controlled and that she could stop the preventer treatment, which in fact was controlling her asthma at that stage. In fact, after the attack, the dose of preventer should have been increased. The dose was appropriate when the child was 5 years old, but now 4 years later needed to be increased. And that attack, in fact both of these attacks, were signals that something needed to be changed. So the key message here is for doctors, particularly in primary care, who delegate asthma care to individuals who are not adequately trained in asthma management. In fact, the General Medical Council have recently reinforced the need to ensure that anyone delegated to care for a patient by a doctor is adequately trained, has the necessary competencies to do the job, and is properly supervised. Unfortunately, the political directive in the UK for doctors to delegate care to increase access to advice without ensuring quality of that advice is currently driving managers and GPs to delegate more. This is dangerous. So for patients, a key message is to ask whether the person they are consulting for an asthma review has appropriate training and is being supervised by a doctor. The problem Mom had in trying to persuade the pharmacist to issue a spacer with a mouthpiece is something that could have been avoided by the issue of an appropriate prescription for a spacer with a mouthpiece. Spacers with masks are not appropriate for children who can use one with a mouthpiece, and this is usually the case for a child once they have reached the age of 3 years. Now, the other major lesson from this near-miss event, where the outcome could have been tragic, is for receptionists in ED departments as well as primary care. If a patient, especially a child, who cannot speak for themselves, attends with an asthma attack They should be seen by an appropriately trained nurse or doctor as soon as possible. This is an emergency. The thing to realize is that many people who have asthma attacks will follow their doctor's advice and take reliever medication, which is usually very effective. So when the person attends the emergency department or the practice, they may seem okay because that drug works very quickly. However, it's important to realize that an attack means that there's something seriously wrong with the chronic management, and also that emergency reliever medication will wear off in about 4 hours. So in my view, practices and emergency departments should ensure that reception staff are trained to manage people who attend with acute asthma attacks. And the receptionists could, in fact, in my own experience, in my own practice, receptionists could help to save people's lives by ensuring that they are seen urgently when attending for an asthma attack. Now, the other point that I wanted to make before finishing is really that this second asthma attack that this child presented with, the life-threatening attack, where she had required 22 puffs of salbutamol before Mom brought her into hospital, and where she had been left waiting in the accident and emergency department for 2.5 hours before she was seen by a doctor. And then she was only kept in for another half an hour before being discharged home. And in my view, this is unsafe practice. In a child who's had a severe life-threatening asthma attack, to send her home without waiting for 4 hours to elapse after emergency treatment with short-acting beta agonist, even in this case where it was administered by the mother before coming into hospital, and also without referring a child to see a pediatric asthma specialist before discharge, or at least arranging a follow-up appointment, is unsafe practice and should not be happening in 2024, 10 years after the National Review of Asthma Deaths was published in the United Kingdom. So I'd like to thank the parents of this child for giving me permission to share her story, and I do hope that doctors working in primary care and in emergency departments will learn some of the lessons that are clearly needed to be learned from this child's story. And finally, that reception staff in ED departments and in general practices are trained to be more sympathetic to patients who attend with acute asthma attacks.